Numero 1, dovete lavare le mani. E che è una novità? Quante volte ve l'ho detto io? Vi sei lavate le mani? No, perché c'è il coronavirus. Per sempre. Siete lavate le mani. Andate a lavare. Secondo consiglio, quando starnutite, dovete starnutire nel gomito. Non è coronavirus. Educazione. Quante volte vi ho detto? Metti la mano davanti. E mo vi dico, metti il gomito davanti. Ma metto il ginocchio? Mettiamo il ginocchio davanti. È più figo. Perché potete fare... Acciun! Ui, come figo? Lo starnuto che me ne frega? Acciun! Terzo consiglio, per un poco di tempo dobbiamo evitare baci e abbracci, perché hanno detto è pericoloso. E noi che potremmo fare? Quando ci vediamo, invece dei baci e abbracci, facciamo l'occhiolino. Zia Maria! E non ci tocchiamo. Hai mangiato, bella nonna? Come stai sciupato? Ti piace? Facciamo così. Una cosa importante, non discriminiamo le etnie per il coronavirus. Noi che siamo abituati a essere discriminati, vogliamo essere noi a discriminare? Ma il virus è colpa dei cinesi, un'altra cosa è colpa dell'africano. Ricordatevi, il coronavirus passa, la discriminazione resta. Non c'è sta vaccino. La quarantena. Che faccio 14 giorni a casa? Approfittate. Potete vedere la puntata, pulite i vetri, ma soprattutto a me mi mettete in quarantena 14 giorni e faccio pepitare il sugo 14 giorni. Arriva a Pasqua è una crema. Dopo 14 giorni che pepitea me lo vendo a peso d'oro. Atica mucchina 100 mm di ragù 400 euro. Sto scherzando, lo do gratis.
Namaste and welcome to the Federal. Continuing with our series on the COVID 19 coronavirus coverage, today we would be talking with an infectious disease specialist, Dr. Deeptha Nedunchezian, who will be joining us from Florida. Um, we have been now, I mean, even at we are seeing a global pandemic as far as COVID-19 is concerned. The WHO also has now called it pandemic, although the idea of calling it a pandemic does not mean to create panic or anything like that, but just means an increased level of preparedness. To discuss more about COVID 19, about the virus, about the drug and the clinical trials going on in the drug, we're joined by Dr. Deeptha Nedunchezian. They're not logged in? No, you need to, they're not there? Hello, namaste, as you were just saying. So, thank you, Dr. Deeptha Nedunchezian, for having joined us for this live webcast. Straight away, question: how are things out there? Are you all safe? Are things fine? How is New York doing? And what has been the response so far?
Hi, Venkat, and nice to see you. And thank you for inviting me for this program. And as you know, that my experience in antiviral infections and being an infectious disease specialist from 1982 has put me right on the spot. Even though I retired about 2 years ago, I've been still keeping in touch with all of the medical information, as well as been conducting many of the continuing medical education program for doctors and others, both in New York, New Jersey, as well as entire USA, mainly for American Tamil Medical Associations and doctors associations. And I do have to say, being a New Yorker who is now staying in Florida for a short time, New York is a place where we are almost always prepared for everything. As you know, starting from 9/11, we have had a command center, and both for bioterrorism, terrorism, as well as infectious diseases, and any kind of crises. So I really need to commend the people who started this Department of Homeland Security, which started putting it all together after 9/11. I think with that, and New York being the gateway to United States, we are at a good point. There has been a lot of information given in USA as well as in New York. Yes, there are some people who are panicking, but most of the people are just well informed, going about what they are doing. We have started our radical control measure only from last week, because even though we knew it was coming to our shores, we had to wait till the cases are coming, and we have to know what is the amount of infections we have started. The way we are working now is, if you have an index case in New York, that is a person who has turned positive for the coronavirus, which is the COVID-19 disease, or if we see a person with infection, that is, they have symptoms of cough, cold, sore throat, or shortness of breath, difficulty in breathing, when there is an index case, we are going around 1 mile radius to do control measures.
Okay.
At this point, I think as of yesterday, there were about more than 150 cases in New York. And the main area was in what we call in Westchester County, which is about 25 miles onwards north of New York City. And all of the cases there started from one person who is a lawyer. And a lot of the Westchester County, and on the east of New York, there is Queens and Long Island. On the south of New York, there is Brooklyn and Staten Island, New York, Manhattan. And then, of course, on the west, you have New Jersey. All these surroundings areas, people come on a daily basis to New York City. They work and then they go back. So our reach of a person from a New York City extends on an average up to minimum 30-mile radius.
Okay.
And some even come very far. So the reason why some measures which are taken in New York is not just because it is for New York City, it is also prevention extending into the other community. I just want to give you a scenario of what happened with the first two cases in New York City. The first one was a person who traveled from abroad. If I'm not mistaken, it may be from Iraq. And
Iran. Oh, okay.
Iran or Iraq, I'm forgetting that. He came, that was about 15 days ago. He came to the New York City, he stayed in, and he immediately realized that he had symptoms, and he went to the hospital, he was tested. And it just, at those days, it took us about two days to get the test results. But now we are at a much faster track. And he was the first one, and he was kept in the hospital. Immediately, contact tracing was all done, and his immediate family members were all contacted, tested, and they kept in quarantine. So, following him, as far as I know, there was no secondary cases. But the main major issue was uh, a male who traveled from Miami on a plane, and he works in the midtown of Manhattan, which means that the middle of the business district of New York City, with the high rises and density, which is phenomenal, which is almost similar to what you would see uh, in the dense population of Bombay, Mumbai, or in Chennai. And he had stayed at work, and he had symptoms, He had some cough and cold symptoms like that. In spite of it, like any other normal person who tends to do that, because I don't think we could blame anybody, because most of us work, and a common cold or a cough, unless you are in a healthcare field, you usually go back to work and you wash your hands and you continue with that, because that is normal. If we cannot we cannot abstain ourselves from work because of some sore throat
True,
and things
true.
like that. So,
So
and that's exactly.
I mean, I'm sorry to come in. So, no, so one thing which you're particularly talking about in this case, right? I mean, as you said, you're somebody who's experienced through a vast, I mean, as infectious disease, right from, I'm sure, like I'm aware. I mean, from HIV through, right through till the last Ebola. How do you
Yes.
think this is different, or how do you think New York has reacted to this differently from what has been done in the past? Was there any difference? And uh, oh, you cut out. Yeah, so please hold on. We're trying to connect back. Uh, yeah. Now, yep. Yeah, you're back now. Sorry, we had a small
Yes.
connection issue. Yeah. So, how do you think this is it any different this time? Or is there any noticeable difference between the way in which this particular COVID-19, be it in terms of reaction of people across the board, this is what they call as the first disc, that is a disease in time of social media, right? So have people, how has this been, or this pandemic, which we can use the word right now, how different is it than it has been in the past? I mean, out of your experience or what you've seen.
I think this is completely different than what we have ever done before in infectious diseases in this country, because most of the other infectious diseases were usually contained to one place. Like, let's take, say, for example, we had SARS, which is the severe respiratory diseases, which is also another coronavirus, which happened in 2000, and that also came from China, but it affected few people, and it was we knew where the source was, and it spread much lower. That means that the spread of disease from one person to other person was much, much lower than where it is. That is, the infection rate was lower. And since we knew, and it is also much slower spread, it went from China, then went to Hong Kong and other places, we were able to institute screening right from the beginning from those countries. One of the, and also with Ebola, since it was only in the West Africa, in one or two countries, we could see them right from the source itself. We stopped it, and if some, we would screen them, we will talk to them, and then as soon as they landed in the United States, we also followed them. And in both the conditions, the spread was not as extensive. That is, the virus was not present in the surrounding as much as this virus is. In Ebola, you really need to be in contact with the person very close. That is, you should be taking care of them. So it was in the saliva and the body fluid. But if you stood away from them for 1 feet or 2 feet, or you just rubbed when you walked along with them or you touched something else in the area they were, it did not come. SARS also was very similar to that. Whereas this virus, because it's in the droplets coming out of the mouth, like as we speak, we are spitting, it's flying. And you do know there are people with showers when they talk. And it is present in that kind of a throat secretions quietly. And also, I would say that uh, many of the people who have the virus do not have any symptoms, or if they have very mild
Yeah,
symptoms,
so
that is another reason.
yeah. So this whole asymptomatic feature of this particular disease, is that also another problem for number of cases that are not being you know coming out,
Yes.
and another on the same context in terms of number of kits or the test kits. They're out. The network is out.
Quando ci vediamo, invece di baci e abbracci, facciamo l'occhiolino. Zia Maria! Non ci tocchiamo. Hai mangiato, bella nonna? Come stai sciupato? Ti piace? Facciamo così. Una cosa importante. Non discriminiamo le etnie per il coronavirus. Noi che siamo
We are,
Yeah, you're back. Thank you. I mean, you seem to have a patchy connection, but yeah,
yes,
please,
I'm
please go ahead.
sorry. It is, I think, because of the international connection, probably, as well as something is happening. And
Yeah.
as I said before, that is one of the things. Anytime when you have an infection, when we say symptomatic, that means somebody will have the virus, but they don't have anything, the body doesn't show any reaction to it. So you're walking around, and it happens in many diseases, but we don't transmit those bacteria, viruses, and the agents to others. Whereas in this case, since it is the virus which you came from an animal source to humans, the entire human species does not have never had a reaction to it. So we don't have the immunity which we need to prevent it. That was the reason why it infects everybody who touches it and gets it. So it is in like if you have influenza, flu, or other bacteria, you may touch it, your body will get the virus, but then the virus or the bacteria, the body will recognize it, and we make antibodies, we control it. It happens to all of us. That's why you could be sitting close to a person at work who might have had a flu. He said he had flu and he goes home. You won't get it, and your friend won't get it, but somebody else gets it. It's just the way how your body reacts. Whereas in this one, we do know that if you sat close to a person who was coughing and you're sharing and touching the same area, and you will get it. That's where we are looking at it now. That is different because this is a virus which is very unique to us because it's coming to us for the first. We have similar viruses before, same family, but this, we did not have it at all. So the human population at this point, it does not have any immunity, and the body is unable to fight it. That is the principle which is used for the vaccine.
Okay.
Vaccine is,
We'll come to the vaccine a bit, but before even the vaccine, about these different types of these coronaviruses, and also in terms of the drug discovery process in that, if you could just briefly touch upon these for our viewers.
okay. The coronaviruses have been with us for many, many, many viruses. Corona means a radius or a head or a crown. That means the virus is a round particle with these projections on it. It looks like a crown or a halo. That is the reason it is called corona. Like we say the corona of the sun and things like that. That is the round thing, That is why it's called corona. So you can imagine when they have this picture of the uh, gray with a red dot, that is exactly what it is. Like a crown which you're wearing it. And that is the reason for it. It's called coronavirus. We've had coronaviruses all the time, and as far as we know at this point, there are 7 varieties of coronaviruses. Out of the 7, 4 of them have been giving rise to common cough and cold for many years. We've been walking around with those common cough and cold and all that, and they've been coronaviruses, and we didn't do much. We didn't think that they were of any big significance, so we didn't look for any medications. And unfortunately, those common cold viruses did not give any immunity for this coronavirus. This is a different one. It changed. It is like if you have a family and you maybe have the same last name, but you still have a different person. You will have Venkat and you will have Arun or somebody else. But they may share the same common name. That is exactly what it looks like. That is the way I would have to describe it. So after the 4 which has been around, the 5th one, which was the novel one, which caused the disease, was the SARS, which came in 2000. So that became SARS, CoV-1, CoV-1. That was the one. So we don't say 1 because that is the one. So the second one was MERS, which is the Middle Eastern coronavirus. That happened mainly in the Middle Eastern countries, Arabia, Yemen, Oman, all that area. Came from contact was camels. And it also gave rise to severe respiratory infection again. That means cough, cold, breathing difficulty, but contained itself to that area, and it's so that you have to have contact with that animal. So the third one is what we are going through now, which is called SARS-CoV, that is acute respiratory syndrome, CoV-2. This is 2. So this is, and that is the virus. The disease is called COVID-19, that is coronavirus infectious diseases 19. So COVID-19 is what people are going through now. The virus is the number 2 virus. All these viruses seem to have an animal reservoir. These are all, I need to let everybody know that humans, animals, mammals, fish, dolphins, whatever you think of, monkeys, they all have their own varieties of infections going around in them. They don't come to us, we don't go to them, but occasionally they change species and they change the genetic and they come to us. Of course, one was HIV, which was in the macaque monkeys, and then we think that it changed the genetic profile, and then that is where it came from simian HIV, from there to human. And same way, this coronavirus had been in animals. We think it may be from bats, maybe snake or others. So it moved from that species to our species by contamination in the area where they kill them on the markets. It could have changed its genetic profile a little bit, and that's why it is it's dangerous to humans. Or we never had it, so it is new for us. But they are handling it well in their animals. So occasionally we see this, when you have contact with animals and humans. We've seen that in other viruses too. So that is the feature of it. So right now, I just want to tell you that
the other part was the drug discovery. I mean, I'm sure you've seen, even in the case of, even you must have seen it with HIV infection, right through all these. So how is this whole drug discovery process? Where are we in terms of a cure or a drug which can cure COVID-19? Where can we go forward on this?
Okay. The drug discovery process is very interesting. I have to tell you that for many, many years, still, I would say probably when I was in fellowship, we had a drug for herpes viruses. There are 2 kinds of viruses. One, or what we call a DNA virus. They are viruses which stay in our body for a long time. And for those viruses, and some RNA viruses, which are like measles. So when we knew way back in early 30s, 1930s, 40s, when all these infections which came along, which is the measles, mumps, German measles, polio, we realized that we need to do something to prevent the infection. We could not isolate them at that time because we did not know they were infecting. They were causing lot of death as well as morbidity. That means they left people lame or mentally challenged, a lot of issues. So that is where the vaccines came along to do massive vaccination. Then there are other diseases which came only for individuals, where vaccine was unable to do it, and we need not do it. That is when we went into drug discovery, because we realized, and one of the reasons why drug discovery also came along is we didn't know for a long time how to do viral cultures. So we learned that over cell culture. We need electron microscopy. So as the science progressed, we started taking the viral particle to see where it acts. We know that the virus multiplies by using several enzymes, and those are the enzymes which we target. And we have enzymes, two or three enzymes which we use for the like the chicken pox and the what we call a herpes zoster. In Tamil they say akki, and or people who get that herpes simplex, the fever blisters, tongue ulcers, all that we realize we can do one, and we do have medications. What does is that it changes, the virus grows with small protein molecules or amino acids. We change an amino acid. So we dupe the virus, it incorporates the wrong amino acid, and it couldn't grow anymore. So that was one variety of changing the amino acid. Then they multiply by using an enzyme called reverse transcriptase. That is, they form the helix and they turn it around, they connect themselves. So then we realized, okay, we can stop that particular enzyme. So that was what used for the early form of HIV infection, all the reverse transcriptase. Then we realized these viruses multiply, they form themselves, they multiply, they become more, and they get out of it. So that is where the protease inhibitors, that is, they form a lot of proteins joined together. That we realize, so then we have protease inhibitors, and they're very effective. So at this point, we have now several targets also for viruses. And then the virus attaches itself to our cell, usually a lymphocyte, which is one of the blood cell in the body. So we also have target for that too. And then we have a target where the virus has to come out of the T lymphocyte and circulate in the body. We have a target to stop that. So these are all the targets where we have. And the scientist and the molecular biologist and what shall I say, biochemists constantly work on medications. They will find a medication, they will use it, and they may find that it may have some activity, not enough, they'll put it in the shelf. So we have several molecules like that which have been shelved. We have them. And every now and then when disease comes like this, we'll pull out one of them. We know there's a group we'll pull out. That's exactly what's happening with remdesivir. It was worked on prior, and they used it somewhat in Ebola. We don't know exactly where it is. So we looked at all of the existent protease inhibitors, because that's rapidly it stops. This one is rapidly multiplying. I said, okay, let's do that. So they looked at that. As far as I know, when they looked at it, there were 3 of them had activity. One of them, I read about it, which is called nelfinavir, which is Viracept, which is very extensively used in HIV, had great activity, but better medications came, so that was not manufactured. But it has gone through human trials and everything. Then other one was Kaletra, which was also extensively used. People are still taking it. That also seemed to have activity. And remdesivir, which is REMDESVR, that is a new one. That was used before in SARS virus and Ebola. We're not sure how active it is. We know that it is active in test tubes, maybe in some people in killing the virus. but we never really do not know whether it is a complete cure. So we have taken that molecule because that's a hopeful, as well as Kaletra. I'm not sure whether nelfinavir has been used, but they are used, or they were all used in China because, as you know, that it has the major epidemic. A lot of people were sick. Most of the people got better themselves
I
with
think
some support.
chloroquine also they seem to have mentioned chloroquine, Kaletra, remdesivir, and uh,
Nelfinavir.
yeah,
Yes,
yeah.
chloroquine has been also used before in many medication. Chloroquine has a lot of activity. It is actually primarily anti-malarial drug. It's a drug which was used for malaria parasite. It's also used for other parasites too. Then over the years, we realized that it may have activity against your body immune system. So we are using it for other diseases also, topically for lupus and things like that. We have also used where we can modify the work of the T lymphocyte. There are some in transplantation they've looked at. So the chloroquine, in my opinion, I don't know whether it has direct activity on the virus, but it probably modifies your immune system to act better so that the virus helps the virus to remove, help your body, and then it works. So we are still waiting on the exact activity of chloroquine. So the chloroquine also is being used in China. We have now used remdesivir in, as well as Kaletra, in Seattle primarily. It's possible they have used it in some of the severe cases in New York or in other places. The main severe cases are all in Seattle, in Washington State, which is on the west coast of United States. That's where, and unfortunately, it got into a nursing home where, as you know, in nursing home, old people are there, elderly people, or even younger people, but who have already a reason to stay. They are connected to the ventilator and they are comatose, their body functions are lower, they have chronic pneumonia, they have ulcers in the body, they have severe kidney failure. So their immune system is very low. They cannot afford to get even regular virus like influenza. So with this virus, they got very sick. So we have used them now, and we will be collecting data. There seems to be some improvement with these people, but many of them have died in spite of the medication. So people are looking at, WHO is looking at all of the data on China, another country, and Seattle. We should have some information about the
Yeah,
efficacy.
so that's a very interesting point which I wanted to make. Arguably, Seattle has one of the best public health system in the world, right?
Yes.
Okay, Tamil Nadu. I'm from India. We are from India, Tamil Nadu, right? There's no way we could compare. But how is it that in a place which has such an advanced public health system, what went wrong? And part B of that question is they were saying that even test kits were not available, with which people could be testing on that. So how important are these test kits, and what is the lesson that countries like us, Tamil Nadu in India, we actually have a reasonably better off public health system. Kerala, Tamil Nadu, West Bengal, when compared to the rest. But nevertheless, what could public health system in places like India learn from this particular experience?
Okay, let me answer one question by one question. You have a lot, 4 or 5 things there. Number one, what went wrong with Seattle? I think our first introduction was the people who were infected in the cruise from Japan who were taken out, and uh, knowingly or unknowingly, the people who are positive for coronavirus and the people who are negative for coronavirus were put on one plane that they brought back to United States. And they went brought back to United States, and they were greeted by many people. And all those members were not advised on how to keep away from them. They were not public health people. They were just regular guys who said hello, and they brought them in to quarantine in one area. And then some of them were released when they were negative. And we did not realize, I think to some degree, how aggressively that virus spread. So some of the people who were released in the community with so-called negative test or not tested, having been negative in Japan, but they traveled in the plane and then they came down. So there was a period of time they might have been reinfected or newly infected, went to one of these nursing homes. On that nursing home, they were moving around for several days. They infected those nursing home people, and then the people in the nursing home, those people going into the community and the using all over the place. Like you go home, you expose your family, and then the man in the family goes to work, the wife goes to some other place, she works or she goes to
Community spread,
school.
basically community
Yes, that is how it happened in Seattle. I think with the test kit, that is a little of a puzzle. We should have been prepared. We should have had thousands and thousands of test kits available. So as soon as they come in, we should have had them available. I am not sure where the chain of command and the communication dropped there, because that to all of us is a puzzle, because the tests were available in other countries. We did not make them here because there was potential to make it, maybe they were not given the orders or somewhere along the line. That I have to say that is a mishap, a little unusual, but I think they realized it immediately. So now we are producing a lot of tests here at South. And so that brings you to the next one, which is, yes, testing is the best way to do it. Because if you have one index case, one person, then there are so many people around them are infected. So you can either go from one index case and then test everybody, or test everybody who's coming from a high risk area and then release them out. Okay, that is the way to do it. So if you test a person who has, say that, let me see, that there is for some reason a person who was in Milan last week and he traveled from Milan out to Rome, and they did not close the Italy, and last week he was up in on the way, and then he came down to Chennai, because you have a lot of textiles and fashion which goes around. They come there to Chennai, and he came in. So he got around 2 days ago. Ideal is to find out when he comes to Chennai right there itself. Okay, when they write in. Best thing is to when he's boarding for Chennai on that side. Ideal is, you have traveled all over the place. That person should ideally be told, and then the Chennai people should have been informed. So when he comes in, or when you come in, you take them aside. You take all of these people who come from high risk area, take them aside, and you need to test them. And if they have no symptoms, you can say, go home, keep to yourself in your room. Don't go anywhere for
self.
24 hours.
Yeah.
That is called quarantine. Quarantine means that you don't know where you are at. You may be at risk of giving it to other people. And then you stay home, you do whatever you need to do, we will call you back. And if you get a positive test, then you get back to them and say, you know what, you have a positive test. You make your own self-isolated at home. You have no symptoms. Stay, and we should provide food and everything for them to there. They can clean up the place and stay in, or take him to a room with his own bathroom, and he can take care of himself and all that stuff. And he cleans up the area, he stays there. Contact with him with others should be restricted. If you're going to have a contact, then we should be wearing, first of all, preferably that person who's infected should wear a mask, because they may cough without realizing it. Once they have symptoms, and more if they need medical care, best thing is you call the hospital or you call your contact, because all these people will have contact. And that person should be honest enough to say where all I went before I put myself in quarantine. Because this is, and then others should not panic or should not be afraid government is going to do something to me. They should come forward and say, you know what, I did this. And then you test them. Testing people massively and keeping them away from each other is the way. And the other way is what we are doing in New York City. Don't have crowds and crowds of people in one area where there's a close contact, everybody's touching, there's coughing, shouting, dancing, and all those things you see in the music festivals and
Right.
basketball matches.
New Eve.
Yeah. So that's what we are doing now, where there is a lot of emotion, screaming, coughing, testing everybody's doing, because you're doing, you're spilling it out. Other people are there. It's falling all over you. You can't, that is where prevention of crowd. And then the third question is, yes, what should your India do? And I completely agree with you that Madras, Tamil Nadu, and Chennai are one of the forefront medical care. Everybody knows about that. In fact, I was there recently because we are also trying to do some other uh, work with the Anna University for emergency care, things like that. And I'm a proud graduate of Madras Medical College from Chennai. So I have to say that Chennai, everybody should know that the Tamil Nadu universities have such high reputation in the United States. So if you apply for a work or you come, they do know that it's a quality work. So our public health system in Chennai is very good, and I am confident they will ramp up. As you can see, the government of India has issued many informations about visas and follow-up. In fact, I have to say that I was in Chennai in January 27th and 28th. On January 27th, I talked to people who came from Australia. Though that time there are two or three cases in Australia, and some of them, as you know, come through Hong Kong. There is a layover or they stay up and all that. Everybody who came from Australia that day, that particular aeroplane, were all screened. This was in January 27th. So you guys were ahead of the game. And I think we were also doing it, but the number of people coming into this country in different fort in the United States is so much, we could not follow up. And then people hopping from one country to other. And I think you already have that. So best thing is for you is to advise is to, like other public health official might tell you, is to have a person doing a command, which should be a government person. Underneath them, you need to have the departments, which will be your medical department, your prevention department, and your physicians, all of that, and the pharmaceutical company. Underneath that, you will have all the scientific people on that, and the scientific people should be informing the others. And you can have, knowing that, I'm sure Tamil Nadu and Chennai had epidemics, not epidemics, outbreaks with cholera and measles and different things, typhoid. They periodically have. You had a dengue fever and you had guinea, chikungunya. So you do have different things. So there is an underlying way of evaluating, where are they coming from, where can we start, how can we protect them. And I think you do have a structure. The structure needs to be put together again. It's there dormant, bring it back again. Much better to do it before it gets out of hand rather than once it is out. That's what happened with China. Once it got out, it became, and that's exactly what happened with Italy. The first, it was in Milan, and they were thinking, and there was other issues, and then it spread out. Now Italy is in a lockdown. So we were little, I have to say, in the 1 to 5 level, we were not at the 5 completely prepared. We were at a 2.5. So that's where we are suffering now. Now we are gone on to 5 plus. But we need to do that because of that. I think, unfortunately, that is where it is. And I think I answered your questions, most of them.
Yeah, that's, thank you. I mean, you cleared, clarified so many of our doubts and questions. Thank you so much for having taken time. I wish we could go on, but time constraint. I'm going to stop here. So thank you very much. I'd just like to end by saying these are the 3 basic advice which the WHO had said, which was keep washing your hands with soap, avoid crowd or travel, and maintain social distance if there's somebody who's infected. I think these are simple guidelines, and it's easy for all of us to follow, and we must try to do our best to fight this pandemic. Thank you all so much. Thank you so much, Dr. Deeptha, for having joined us at the Federal. Thank you very much. Namaste, and you're watching the Federal.